presenter and facilitator today. This webinar is on chiropractic best practices, clinical practice guidelines for the chiropractic treatment of neck pain and whiplash injuries. And today is Tuesday, February 13th, 2018. We are here with my friends at the Virginia Chiropractic Association, and I'm again so pleased to be here today with you. I spoke with you all a couple of weeks ago, and we had a wonderful time talking about the chiropractic guidelines for chiropractic treatment of low back conditions. So today we're going to be moving on to some other guidelines for the treatment of neck pain and whiplash injuries. What I'd like to do is do a little bit of a review from last time. Let me get to the next slide. The last time we were together, we discussed the best practices for treatment of low back conditions using the CCGPP guidelines for the treatment of low back disorders. And we had a pretty good discussion on the advantages of using accepted, published, and documented scientific evidence for case management of the chiropractic patient. As I mentioned to you last time we were together, one of the things that I hear a lot from chiropractors, or am asked a lot as a practice consultant, and we have a Gold Star Medical is also an outsourced medical billing company, so we have many chiropractors that we deal with, that we do billing for, and many times they will contact me and they'll ask me, well, how many visits can I get for this Medicare patient, or how many visits is this Blue Cross plan going to pay for, and will the Blue Cross plan pay for more physical therapy benefits even after the chiropractic benefits are exhausted? What are the number of visits I can get? And as we discussed a few weeks ago, in reiteration, I think that's the wrong question to ask. I think the right question to ask instead is, how many visits does this patient need based on their clinical presentation, based on the scientific evidence that is out there, and the best practice guidelines that I can follow to perform better case management on my patients? So we discussed the advantages of using these accepted, published, and documented guidelines for case management of the chiropractic patient. Number one is using the guidelines gives you meat to your patient education and retention. Reported findings are better. Your patients are more likely to stay with their treatment plan and move on to supportive care, because then they understand the science behind it, because that is how you're presenting it to them. It fosters a population of wellness patients, and let's face it, I would venture to say that most of you who are listening to this webinar, and if you're going to listen to this later on, would say, I would love to have a almost 100% maintenance practice and not have to rely on getting new patients every month and doing marketing activities and spending money on advertising. And I would love to have my patients referring other patients and be a 100% referral practice and get 50 new patients a month. Well, if you're going to do that, then you're going to have satisfied patients who are going to be coming back for routine chiropractic care on a supportive level. And these best practices will enable you to do that much more successfully within your practices. So utilizing the scientific guidelines will increase patient referrals, and it will improve cross referrals with the mainstream medical community. So, excuse me, so if you have been struggling or frustrated with the fact that you don't get very many referrals from medical doctors, if you're utilizing the guidelines and the medical doctors are aware of this through you sending them routine reports and updates of their patients, then they're going to be much more likely to refer patients to you and vice versa. It also improves your documentation and mitigates audit risk, and that's a huge deal right now. Audits are on the rise. They don't it doesn't appear that they're going to go away anytime soon. So if you want to make sure that your documentation is fairly bulletproof and can withstand an audit, if you're documenting and case managing your patients based on the scientific guidelines or a scientific guideline, you have a point of argument with an insurance company. It improves your ability to successfully appeal claims. And so we discussed all of these in a lot more detail in our last presentation. So if you would like to get more meat on these topics, I would recommend that you go back and get the recording from the VCA. We have it for you. If you've registered for these webinars and you weren't able to attend, or you were one of the unfortunate ones last week who did attend and didn't get the video of the presentation, I did re-record it for you. And so you can go back to the VCA website and contact either Pam or Julie, and they'll go ahead and get you that recording of the last webinar that we did 2 weeks ago. So what we're going to talk about today are the guidelines that are out there for you to utilize and to draw from for patients who come and present to your office with neck pain and or whiplash disorders. Now, the CCGPP, which is the clinical compass, the organization that we utilized for the discussion of the low back guidelines, okay, they currently do not have published guidelines themselves for cervical disorders. They are currently working on this. I spoke with and emailed Dr. Jay Greenstein, who's the president of Clinical Compass and the CCGPP, and they're in the process right now of working on this for the guidelines for cervical disorders. And when I asked him about which guidelines are they going to be looking at adopting or that they recommend at this time, Dr. Greenstein pointed me to the CCGI guidelines that are through the Canadian Chiropractic Association. So these are the guidelines that we're going to be talking about today. Dr. Greenstein said that he actually has taught on the Ontario protocols and on the CCGI guidelines and has found them to be extremely helpful for the chiropractic profession. And so since he's probably at the forefront of campaigning and really working towards moving the chiropractic profession to utilizing these scientific guidelines, if he says it's good enough for him, then it's good enough for me. And so without further ado, let's go ahead and talk about some of these papers. Now, when I started doing research on these guidelines myself, I realized that the Canadian Chiropractic Association actually broke these guidelines down into 3 components. There is a guideline for non-specific neck pain. There is a guideline for a more specific neck pain, or they call neck pain associated disorders, or NAD, and then they have whiplash associated disorders, or WAD, W-A-D. And there are 3 distinct guidelines and papers for these different types of cervical presentations. And so the first one we're going to talk about today is the clinical practice guideline for the chiropractic treatment of adults with neck pain, and this is for the non-specific neck disorders. This is a fully accredited guideline through the Canadian Chiropractic Association under the auspices of the Canadian Federation of Chiropractic Regulatory and Education Accrediting Boards, the Clinical Practice Guidelines Project. And so these studies have been fully vetted through well-known and accredited organizations. And so you can take these guidelines and utilize them as your guideline for scientific evidence. The full guideline for this particular discussion that we're going to have on the non-specific neck pain was published in the Journal of Manipulative and Physiotherapeutics, Evidence-Based Guidelines for Chiropractic Treatment of Adults with Neck Pain was published in 2014, volume 37, pages 42 to 63, and I have attached the white paper on this to your invitation, so you should have received with your handouts the full white paper on this. What we're going to be talking about, of course, since we only have an hour to discuss these different guidelines, is the highlights. And so we're going to talk about the highlights of these guidelines and how they can help you better case manage your patients with neck pain. So one of the things that I found very interesting, this is a great talking point when you're discussing neck pain with your patients during your report of findings. So first of all, 30 to 50% of the population will suffer from neck pain at least once a year. That's a lot of people. Persistent or recurrent neck pain is estimated to be reported by 50 to 85% of patients 1 to 5 years after initial onset. So what that tells me is that nonspecific neck pain can become a chronic condition. And we're going to discuss, again, there are specific elements to treatment of chronic conditions that you must be aware of and you must be documenting in order to get those conditions paid for by the insurance companies. Its course, based on the study, is usually episodic, and complete recovery is uncommon for most patients. So, I mean, if you're going to do a report of findings and you want to do the bad news, good news, you know, the bad news is that persistent or recurrent neck pain is estimated to be reported by 50 to 85% of patients 1 to 5 years after initial onset. This can also be incorporated into your informed consent so that patients are aware that neck pain isn't something that, well, I'm just going to go to the chiropractor and it's going to, you know, they're going to pop my neck, as they say, and it's going to go away after 2 or 3 visits and I never have to come back. And the fact that complete recovery is uncommon for most patients is worth telling the patient, because that already begins then to plant the seed that this patient may have to come back from time to time for treatment of this possibly chronic neck condition. So be aware of that. 27% of patients seeking chiropractic treatment report neck or cervical problems. The majority of them will initially come in with low back problems, but 27% of patients will seek chiropractic treatment with the initial complaint of neck or cervical problems. And thus, treatment of neck pain is an integral part of chiropractic practice, as we well know. Now, according to the guidelines, the diagnosis for nonspecific neck pain would be supported by a thorough history and examination. And if I'm talking to you as a biller, for those of you who took the webinar last time, as I explained to you, I own a medical billing company, and we do medical billing for literally probably over, I think we have over 40 chiropractors right now that we're doing billing for throughout the United States. And one of the things that I do, and I've gone and gotten a certification as a medical compliance specialist, is chart audits of chiropractors, and specifically my clients. So if you sign up with my company and we do the billing for you, one of the very first things I'm going to do is I'm going to ask to see your documentation, because we have to make sure as a billing company that we're protecting ourselves from the possibility of fraudulent or erroneous billing. When we're sending out claims for you, if we're doing the billing for you, we're assuming that you have documentation that supports the CPT codes and the diagnosis that you're giving us to put on a claim form. So I can't assume anything. So I insist on looking at my doctor's documentation when they first start out with us. And if there are deficiencies in the documentation, we work on improving those deficiencies so that we can be assured as your billing company that the claims are going out correctly. But I also can conduct these chart audits for chiropractors who would like to, maybe you have a fabulous billing department, and that's wonderful, but you're not sure if your documentation is up to snuff. I can conduct a chart audit for you on that to help you determine whether your documentation will hold up against an audit scrutiny. And as I said, audits are on the rise. And one of the things that I find is a great deficiency in the chiropractic documentation in general, and again, I know that some of you are probably listening to this and you're looking at this slide and you're saying, you know what, we've got this, we're good. And if somebody was to audit me, whether it's Medicare or a commercial carrier, I'm fine, bring it on, I'm not worried. But I honestly, most of the chiropractors that I've ever spoken to can't say that. And so I'm going to make an assumption that there are some of you listening to this webinar who may be concerned about your documentation. And so one of the things that I see that's missing is a thorough patient history and physical exam to establish the nature of the condition and to identify any red flags, but not limited to any dissection-related or stroke risk factors or symptoms or comorbidities that might prevent you from treating that patient, or comorbidities that might indicate that this patient may be a candidate for a chronic neck condition. Ask probing questions to understand the key features of the patient's history and symptoms. A full review of systems should be done. Physical exam for the neck conditions should include range of motion, cervical range of motion, orthopedic testing, palpatory exam, and a full neurological exam. Interestingly enough, range of motion testing is not as highly stressed in the low back physical exam as it is in the cervical. When I looked at the studies, cervical range of motion evaluation was all over all three of these studies. So make sure that within your physical exam for the cervical patients that you are including a full range of motion evaluation. Now, for those of you who want to take that range of motion evaluation and really do a comprehensive range of motion evaluation on your patients, you could schedule a separate appointment for that, because there is a billing code for range of motion testing. However, it cannot be done the same day as an evaluation and as an office visit, because they'll get bundled together. They won't get paid together. A range of motion testing can be done. There are separate codes for that, but your documentation would have to show that this was a completely separate encounter in order to have it considered for payment. Should patients show signs of symptoms, what is the range of motion code? I will get that to you. I don't have it off the top of my head. I think it's 95851, but I would have to double check that. Should a patient show signs or symptoms of neurovascular impairment, unilateral facial paresthesia, and some of the other conditions that are listed here in this study, they should be referred for immediate emergency care. And one of the things we're going to talk about is in the second section in the second study, not the second section, where there's a discussion of neck pain associated disorders. They're graded from 1 to 4, and that would be considered a grade 4 disorder, which indicates an immediate referral. And so we'll talk more about that here in just a few minutes. So again, just like the CCGPP guidelines gave you wonderful treatment algorithms for treatment of low back pain, we also have, through the Canadian Chiropractic Association and through the CCGI guideline here, we have an algorithm when a patient comes to you presenting with neck pain to determine the type of neck pain that they have. Number one is, are we looking at a patient with a neck pain associated disorder? And these would be considered patients who have serious local pathology, maybe a tumor or cancer in the spine, or severe osteoporosis, maybe a fracture, systemic disease, radicular source. So if you have pain, that neck pain that radiates down into the arms and the hands and the fingers, then that would immediately be classified as a neck pain associated disorder and not non-specific neck pain. So you would need to determine, are we dealing with non-specific neck pain, a neck pain associated disorder, or a whiplash disorder? And then based on that, you can use this algorithm to decide the appropriate course of treatment or referral to another medical professional if warranted. So some of these things that when it talks about the whiplash associated disorder, we have a completely separate guideline and treatment recommendation for these patients, and this was developed specifically for that condition. It was called the Ontario Protocols, and we'll talk about that here in just a little bit. For a patient showing signs or symptoms that are listed underneath the orange box, they would be referred for immediate emergency care, and there would be certain instances in which a patient with NAD, a grade 4 NAD, for instance, maybe that has serious local pathology, would also be referred out and would not be treated in your practice. And so you would want to make sure that you know what type of neck pain you're dealing with. Now, for non-specific neck pain, which is what we're talking about, if the patient has acute non-specific neck pain, which is less than 3 months of duration, so when did this pain start? If it's been less than 3 months, then we're looking at acute non-specific neck pain. If it's been over 3 months or it's lasted more than 3 months, it's considered chronic non-specific neck pain. And then you'll notice that the algorithm takes you down for the acute through the green boxes, and from the chronic patient, it would be the blue boxes. And so this algorithm can help you very quickly move your patients into the correct path of treatment for the different type of neck pain they may be presenting with. So for treatment recommendations for acute non-specific neck pain, one of the other things that I found very interesting about this is that it was a lot more non-specific than the CCGPP guidelines for low back pain. As you can see, what it says here for acute non-specific neck pain, spinal manipulative therapy is recommended for the treatment of acute neck pain for both short and long-term benefit when used in combination with other treatment modalities, i.e. advice, exercise, and mobilization. 3 separate studies used several treatment sessions, 4 and 5, or on an average of 15 for 2 or 12 weeks. Well, that's a big, broad range of treatment recommendations. 2 weeks, 12 weeks, 4 to 5 treatments, up to 15 treatments. And so the bottom line on the non-specific neck pain is that your examination, your evaluation on the range of motion testing, the orthopedic and the neurological testing, and your clinical judgment will have to be well documented in order for you to justify the frequency of treatments for a patient with acute non-specific neck pain. Do your diligence with regular reevaluations. And so if you're doing range of motion testing on a patient initially, you're going to want to retest them with the same exact range of motion testing and score them accordingly. Make sure that you are showing progress in their care through the regular reevaluations and the routine testing of these patients. For patients with chronic non-specific neck pain, there are a number of recommendations. One is one study stated that spinal manipulative therapy was recommended in the treatment of chronic neck pain for short and long-term benefit, pain and disability. Now, this study used 2 treatments per week for 9 weeks for chronic pain. Spinal therapy also is recommended as part of a multimodal approach, including advice, upper thoracic spinal manipulative therapy, low-level laser therapy, soft tissue, mobilizations, etc., etc. Investigators used a number of treatments over several weeks, in addition to assessing the impact of a single treatment over the short term. Mobilization is recommended for the treatment of chronic neck pain for short-term immediate benefit pain. There was a question that popped up in the chat box about the difference between mobilization and manipulation. And again, I'm not a chiropractor, but from what I understand, the difference between mobilization and manipulation is that you're working specifically with a joint in mobilization, and it is more in line of like a manual traction procedure than an actual dynamic thrust. So mobilization is more in the traction and stretching and targeted at specific joints. Manual therapy is recommended for the treatment of chronic neck pain for short and long-term benefit, and home stretching 3 to 5 times per week with advice and training is recommended in the treatment of chronic neck pain for short and long-term benefits. And this is something that I saw threaded throughout these studies, was the emphasis on teaching patients to do home care for their neck problems, and really harping on them to do so and working with them. So we'll look at this as we see the rest of these studies. Now, remember, when we're talking about chronic problems, chronic neck pain, chronic low back pain, the way a chronic problem needs to be documented is you need to use within your documentation verbiage that relates the issue and the improvement of the issue to improvement in the patient's functional capacity, or ADL, activities of daily living. According to Medicare, if you see the bottom of your screen, this is how Medicare, in the Benefit Policy Manual, Chapter 100-2, I mean, it's right there in black and white, Medicare does consider a chronic subluxation for payment. And in our next webinar, we're going to talk all about Medicare and about how these guidelines and these studies fall right in line with the Medicare guidelines for treatment in the local coverage determination documents. But Medicare defines a chronic subluxation as a condition that is not expected to significantly improve or be resolved with further treatment, as is the case with an acute condition, but where the continued therapy can be expected to result in some functional improvement. Once the clinical status has remained stable for a given condition, without expectation of additional objective clinical improvements, further manipulative treatment is considered maintenance therapy and is not covered. So Medicare is very specific about what they define to be a chronic subluxation. Most commercial insurance carriers follow suit. So most commercial carriers will consider chronic subluxation. And if you're documenting the patient's function and the deterioration and improvement in their ADL throughout the treatment plan, then you're going to be much more likely to avoid recoupment audits where it gets taken back, all the money gets taken back because you didn't document any of this, and you had a diagnosis code of cervicalgia for 30 visits, and yet you did not document the patient's functional impairment. And because of that, Medicare, if you look at the LCDs, they're going to allow anywhere from 6 to 12 visits for a diagnosis of cervicalgia. That's about all you're going to get unless you can prove a chronic subluxation. And so in that case, then you would need to make sure you have some type of a documented system for grading functional disability. And the trademark functional disability index for cervical conditions is the NDI, the Neck Disability Index. It's a modification of the Oswestry Low Back Pain Disability Index. It's got 10 questions or 10 different items, including pain, personal care, lifting, reading, headaches, concentration, work, driving, sleeping, and recreation. and it has sufficient support and usefulness to retain its current status as the most commonly used self-report measure for neck pain. Of course, you can also utilize and incorporate the pain scales, the NRS, numeric rating scale, the visual analog scale, and the verbal rating scale. These are the most used scales in research and clinical practice, and they are considered reliable and valid. I'm getting a lot of questions in the chat box, and that's great. So what I'll be doing is at the end of the presentation today, we will try to get done with enough time for me to be able to ask or answer all of these different questions. But by all means, keep typing them into the chat box, because if for some reason I can't get to your question, I will email back, and I will send the email to Pam or Julie at the VCA, and we'll have an email response back to all of you. So be sure that you put all of your questions down in the chat box. So within this particular study, there is emphasis on rehab and self-care. So the study says, and again, this is coming directly from the verbiage of the study, home strengthening and endurance exercises with advice, training, and supervision are recommended for both short and long-term benefits in the treatment of chronic neck pain. In all studies, home exercises were performed daily to 3 times per week. And I know for a lot of us, we're thinking, yeah, right, our patients aren't going to do that. We hardly even do that ourselves. But it doesn't mean that it should not be recommended. So exercise, including stretching, isometric stabilization, and strengthening, is recommended for short and long-term benefits as part of a multimodal approach to the treatment of chronic neck pain when combined with infrared, massage, or other physical therapies. In these studies, exercises were typically performed 2 to 5 times per week for several weeks. So home strengthening and endurance exercises is a session or 2 or 3 sessions that you have with your patients in the office where you teach them how to do those exercises and how to do them at home. But it's also letting you know, the studies letting you know that do them in the office as well. So have a rehab protocol in addition to your manipulation or your mobilization that incorporates some of these different modalities, whether it be exercises, stretching, massage, it could be infrared radiation or other types of physical therapies. And again, 2 to 5 times per week for several weeks. Now, obviously, it's very difficult to get a patient to come in every day for exercise, but if you can get them to come in 2 to 3 times a week for 3 or 4 weeks, that is going to improve the efficacy of that treatment plan and really give it the meat that it needs to have in order for you to prove that you're utilizing the science to effectively treat these patients. So, have you introduced cervical rehab to your patients? Do you have a cervical rehab protocol as part of your standard treatment plan of your cervical patients? And if the answer is no, ask yourself the question why. You know, maybe you're not comfortable with the protocols. There are many webinars and seminars that you can take on rehab protocols. Do you provide 1 to 3 sessions of home exercise instruction to your patients and recommend cervical home exercises daily to 3 times a week? If so, have you documented that? I talk to doctors all the time that will say to me, oh yeah, I talk to the patients all the time about doing home exercises. And my question is there's a billable code for that, home exercise instruction. I believe it's 97530, and self-care home management training. And you can teach your patients to do these exercises on their own, and it's a billable code to an insurance carrier. And insurance carriers, honestly, we have less problem with payment for rehab and modality codes than we do for spinal manipulation codes, by far. And so most of the commercial carriers will consider these codes for payment, and it's part of the best practices, so why not introduce it into your practice, not only to benefit your patients, but also to benefit your own revenue stream. So let me ask you, massage therapy is mentioned throughout these studies, and the study does say that massage is recommended for the treatment of chronic neck pain for short-term, up to 1 month benefit, when provided in combination with self-care, stretching, and/or exercises. In both studies, 5 to 10 upper body neck massage sessions lasting 60 to 75 minutes were provided. Now, one of the things you have to be aware of is that many carriers do not cover massage therapy as a massage code, and that's code 97124. A mistake that I see many chiropractors make is that they substitute the 97140, which is manual therapy technique, for massage, because manual therapy generally is covered, and under manual therapy, a certain type of massage is covered, which is trigger point therapy or myofascial release. However, I want you to think about a deep tissue massage. To do a deep tissue massage for 10 sessions, 10 times within a 1 month period, if I was an insurance company, I wouldn't buy it. You would really, I've had deep tissue massage, and they are no fun. I usually go and have a trigger point and myofascial massage maybe once every 3 months. And then once a month I'll have a massage in between. But to justify a 97140 as a substitution for massage, you would have to show 60 to 75 minutes of manual lymphatic drainage, trigger point therapy, deep tissue massage, and in all honesty, I don't know very many massage therapists who would do that with a patient at this frequency of visit. So if you're going to incorporate massage correctly into your practice, be aware of the fact that many of the massages that you do will probably have to be paid out of pocket by your patients. And they need to be willing to do that and not put pressure on you to bill the insurance company for a massage that by recoding it something else. That is not correct. And so you need to make sure that you're doing this correctly. And if you have any questions about that and you would like to discuss it with me in more detail, privately, please feel free to give me a call. The first slide has all of my information, my contact information. You feel free to call me about that, and I'll be happy to talk to you. I won't even charge you a penny for it, but this is one of the biggest areas of audit risk for a chiropractor, is the misuse of 97140 in place of massage. So be aware of that and be careful. All right, so now moving on to the other two studies, which really the basis of all three studies is the same, but with a little bit of a different take on it. So now we're going to look at the whiplash-associated disorder study and the neck pain-associated disorder study. So how is this different? How is neck pain-associated disorders different from non-specific neck pain? According to the chiropractic studies, the Canadian chiropractic studies, neck pain-associated disorders are disorders in which you can point to a specific incident that caused the neck pain, essentially. And that's really a very broad statement, but essentially that's what they're getting at. Either a traumatic injury that took place, a fall, you were at Walmart and you were pulling a can off of the shelf and 3 cans fell on your head and you injured your neck. That would be a traumatic injury. Patients who have neck pain with radiculopathy are considered to have neck pain associated disorder, local pathology, systemic disease. And neck pain associated and whiplash associated disorders are classified in these studies into 4 grades. And you can see in this table the different grades. So a grade 1, not NAD or WAD or NOD or WAD, would be no signs or symptoms suggested of major structural pathology and no or minor interference with activities of daily living, okay? So that would be if the ADLs are very, very minor interference. Well, I can't turn my neck all the way, but otherwise I can still lift and I can still do all of the things I normally do, but I'm a little bit restricted turning my neck to the right. A few adjustments will fix that, and then the patient will again have full range of motion. That's probably a grade 1 neck-associated disorder. No signs or symptoms, but major interference with activities of daily living would be a grade 2. No signs or symptoms of major structural pathology, but presence of neurologic signs such as decreased deep tendon reflexes, weakness, or sensory deficits would be considered a grade 3 neck pain associated or whiplash associated disorder, and a grade 4 is a sign or symptom of major structural pathology. Now be aware that that the publication of these studies were again published in the JMPT in 2016, volume 39, number 8, and they very specifically say that they are only dealing with grades 1 through 3 disorders. Grade 4 disorders, they recommend immediate referral. So there is no treatment protocol for a chiropractor in these studies anyway for a grade 4 whiplash or neck pain associated disorder. So be aware of that. So under these guideline initiatives that come directly from these studies, they state that neck pain and its associated disorders are common and result in significant social, psychological, and economic burden. In light of recent research evidence, an update to the recommendations of the management of neck pain associated disorders and whiplash associated disorders was timely. So they basically gave this is about a 69-page document, of which the last 5 or 10 pages gives you an overall executive summary. The majority of the study gives you all of the research that was done, all of the different clinical trials that actually took place and what the results of those clinical trials are. And if you are a researching geek, you can go ahead and read all of those guidelines to your heart's content. But as I was looking through it and I was saying, well, what can I give my friends at the Virginia Chiropractic Association to chew on in a short 1-hour webinar, I found the majority of what I needed in the educational executive summary of the recommendations for neck pain associated disorders and whiplash associated disorders. So the full guideline you should have received as a handout. And also, if you didn't, for some reason, you can go to www.chiroguidelines.org for the full guideline. So here's a summary of recommendations. A multimodal approach, including manual therapy, self-management, advice, and exercise is an effective treatment strategy for both recent onset and persistent neck pain and whiplash associated disorders. And that sounds like very, very simple, but some of the things that you need to be aware of within this recommendation is the word multimodal. So if you are a straight chiropractor and you don't do any type of ancillary service in addition to the chiropractic treatment, then your burden of documentation of the science is going to be greater, especially if your treatment plans take significantly longer for a patient to reach maximum medical improvement than a chiropractor who uses a multimodal approach and can usually complete a treatment plan in anywhere from 1 to 3 months. Medicare looks, and we're going to look at this when we discuss Medicare in 2 weeks, Medicare does not expect any acute condition to be treated for longer than 3 months. And what they say is that is that 3 months is the absolute maximum, but they expect that the majority of conditions are treated successfully, as far as an acute condition is treated successfully within a 30-day period. So be aware of that, a multimodal approach. The other thing to be aware of is self-management. How do you grade yourself on patient education for home exercises for cervical conditions and low back conditions for that matter, but we're dealing with cervical conditions today. So ask yourself those questions. Are you incorporating an exercise regimen or some type of a rehab regimen, even if it's a short term, maybe 2 or 3 weeks of rehab, within your treatment plans for your patients who have neck pain associated disorders? And so the grading of the grade 1 through 4 neck pain associated disorders is found under the 2000 to 2010 Bone and Joint Decade Task Force on Neck Pain and its associated disorders, and then the Quebec Task Force, which are the Ontario papers, which deal specifically with whiplash injury, also grade whiplash, and you can see that it is slightly different, okay, not much different, but you'll notice that if you're dealing with a whiplash patient, then make sure that you're grading them accordingly to the Quebec Task Force classification of whiplash associated disorders. So, and again, they give you this really fabulous treatment algorithm. So if a patient presents with neck pain, what's the next thing that's going to do is to conduct an appropriate clinical evaluation, and we discussed the importance of the history, the examination, and the pertinent range of motion, orthopedic, and neurological testing that needs to be done in order to render a classification to that patient of the type of neck pain they have, whether it's non-specific, a neck pain associated disorder, or a whiplash disorder. Look for risk factors for serious pathology or for a grade 4 neck pain associated disorder, because then if you do, then you can see in this pink box up here, and if there is a serious pathology and the answer is yes, then you stop right there and just refer to a physician. If the answer is no and the patient is going to be graded with a grade 1 through 3, and then you're going to look for prognostic factors. Does the patient have a good prognosis or a poor prognosis? If the patient it looks like they're going to have a poor prognosis, then you need to address that, which would be the comorbidities, environmental factors that could continually aggravate or exacerbate the condition. If not, then you're going to offer, if they have a good prognosis, then you're going to offer information on the nature management course of the treatment and initiate a program of care, which would be setting your treatment plan and your treatment goals. Identify whether treatment is required. If yes, then you move down the algorithm for the type of care. If it is a grade 1 through 1 or 2 NAD, then the recent onset is less than 3 months, meaning that it's acute. Then you look to the far left for multimodal care, manipulation or mobilization, range of motion, home exercises, or multimodal care. So one of the things that I found interesting in this algorithm is that for a grade 3 neck pain associated disorder, and it is a recent onset, you'll notice that spinal manipulation is not indicated. The indication is supervised graded strengthening exercises. And multimodal care or advice alone for persistent, mixed supervised and unsupervised high intensity strength training or advice alone. So for grade 3 neck pain associated disorder, they don't mention spinal manipulation. They mention exercise and multimodal care. So that's something for you to consider when you are looking and assessing your patients with neck pain associated disorders. For the whiplash disorder, there is an algorithm, a separate algorithm. So if the patient presents with whiplash, then you would conduct an appropriate clinical evaluation and again, follow the algorithm. And one of the things that I noticed that was interesting with the whiplash-associated disorders is that multimodal care is only recommended for 3 months on grade 1 and 2 whiplash-associated disorders. So here's my question. For those of you who do personal injury patients or who treat personal injury patients, how long do you hold on to these patients? Are these patients being treated for 4 or 5 months under a personal injury? If so, and they are only really justified at a grade 1 or 2 whiplash-associated disorder, after 3 months, you're looking at a protocol of supervised exercise and not spinal manipulation. So that's something to consider. And so very, very important that you correctly grade these whiplash disorders and that you look at these treatment protocols, because I tell you what, if you're working with an attorney and you show an attorney something like this and you can show them that you are utilizing proven scientific best practices for treatment of whiplash disorders and you're following these protocols, then the attorneys are going to love working with you, because should it come to having to, whether it's an out-of-court settlement or should you have to go to court, you have the science behind it. And you can take this diagram and you can take this study to court and put it up on a big screen and show in your testimony that you followed this exact approach to the treatment of the whiplash disorder for that particular patient. So if you're wanting to beef up your personal injury portion of your practice and you've always been a little unsure of how long should I treat a whiplash patient, when should I cut them loose, utilizing these protocols is really going to help you improve your relationships with the attorneys and improve your relationships, frankly, with the insurance carriers who love to cut us off, after a couple of months of care because we haven't appropriately graded and documented the whiplash injury correctly. So make sure that you understand that, and make sure that you understand and recognize the complexity of treatment of cervical disorders. One of the things that I thought was very interesting in this article, they stated that the clinical management of musculoskeletal disorders and neck pain in particular can be complex and often involves combining multiple interventions to address its symptoms and consequences. In this guideline, multimodal care refers to treatment involving at least 2 distinct therapeutic methods provided by 1 or more healthcare disciplines. Manual therapy, including spinal manipulation, medication, and home exercise with advice, are commonly used multimodal treatments for recent onset and persistent neck pain. Thus, there is a need to determine which treatments or combination of treatments are more effective for managing NOD and WOD. Now, one of the things, again, that I see in general with chiropractors, and again, not to put everybody into one pigeonhole, but I do see this quite a bit, is that the chiropractors like their diagnosis codes. They use, if a patient comes in with a cervical condition, they use the same diagnosis codes in the same order. Very, very little change up. They use the same treatment plans, the same therapies, the same everything. And these patients may actually need more treatment than you're giving them or need less treatment than you're giving them. And maybe they need some of this multimodal care. And so understand the complexity, and if your documentation is showing that you're cognizant of this and that you are following the science and the complexity of the treatment of cervical conditions, then you're going to be much more likely to not have problems on audits for, retrospective audits when an insurance company comes in and sees that, you've got the same type of treatment, the same diagnosis codes, and so on and so forth. You've got to make sure that you're mixing it up sufficiently and appropriately to justify the medical necessity for these treatments. I found this table to be extremely interesting, and this was in the study on treatment of whiplash and neck pain disorders, treatment interventions that should not be offered for neck pain associated disorders grades 1 through 3. And for associated disorders of under 3 months, relaxation massage was contraindicated, a cervical collar, moist heat, electric muscle stimulation. So I found these to be interesting because I see, and this is actually something that I've learned, and so I'm going to be presenting this to my clients because I have a lot of clients who treat acute cervical patients and use electric muscle stim. And I have noticed recently over the last year or so that some auto carriers and even some commercial carriers are beginning to deny muscle stim, and I've wondered why, and it could do with this type of a study. And so just be aware of this and be aware of the treatment protocols that are contraindicated based on the grade of neck pain associated and whiplash associated disorders. Okay, and finally, beef up your treatment plans. So number one, and again, I crossed through about some of this because it didn't apply to what we're talking about right now, but I underlined some of the things that I found to be very pertinent to our discussion today. Number one, patients reporting significant recovery should be discharged. And that just goes without saying. Just because you put a patient on a treatment plan, let's say for 3 months, if a month and a half into their treatment plan, they really are asymptomatic, their ADLs are good, their range of motion is good within normal limits, they're not experiencing any neck pain, you don't continue the treatment plan just because you've recommended it. You congratulate the patient on their recovery, on their speedy recovery, and you move them into supportive care at that point in time. Sometimes hanging on to a patient too long is a bad thing, and I know that chiropractors have a tendency to be a little bit, they want to help their patients out. Their patients will say, if I want to keep coming back, but my insurance won't pay for it. And that's the nature of the beast. So don't keep treating patients because you're trying to be a nice person for this patient and get in trouble with the insurance company because you've treated them for too long. And then somewhere down the road you're audited and it's recognized that you've treated a patient probably 12 to 18 visits too long, and then all that money gets taken back. Well, now you have to go back after the patient. That does not look good. So discharge the patient when it is time to discharge them. Benefits of physical activity and self-management. And again, I told you that this threaded through all 3 of these studies. Educating patients about the benefits of being physically active and participating in their care has become the standard of care internationally. Despite the benefits of therapeutic exercise for managing chronic neck pain and the strong evidence favoring regular physical activity to reduce related comorbidities, care providers fail to routinely prescribe these to patients. Ask yourself the question if you are in that population of care providers who fail to routinely prescribe physical activity and self-management to patients. Now, with that said, if you go to the top of the next column on the patient side, adherence to prescribed exercise programs is often low. We know that, but does that mitigate our responsibility to give them those protocols and those treatments? Okay, so make sure that you are aware of the the importance that is being stressed on home exercise instruction and home and advice to your patients of staying active and staying healthy. This was one of the patient education flyers that was part of the paper, and I believe you can get this from the Canadian Chiropractic Association as a poster, and you can even give it to your patients. So if your patients are suffering from neck pain or whiplash, it just gives a little illustration of the types of therapies that they should be having as part of their treatment. So, summary of the recommendations for grades 1 to 2 neck pain and associated disorders. Okay, neck pain, recent onset, 0 to 3 months. Grades 1 and 2, multimodal care, manipulation or mobilization, range of motion, home exercises, or multimodal manual therapy. For recent onset, neck pain, grade 3, supervised graded strengthening exercises. For persistent less than over 3 months, neck pain, graded 1 through 2, multimodal care or stress self-management, multimodal care or advice alone, manipulation in conjunction with soft tissue therapy, etc., etc. So you can see what the different treatment options are for these patients. Summary of recommendations for grades 1 through 3 whiplash and associated disorders. It's pretty simple. Based on patient preference and practitioner experience, we suggest offering advice with multimodal care, and for over 3 months, supervised exercise or advice alone. All right, so we're finished with the presentation, pretty much right on time. We're supposed to go until 1:30 your time, and we're going to open it up now for questions. So I'm going to open up the menu bar. I will continue to record this so that the questions are recorded. So let's go to the first question. What is the range of motion code? Okay, so the range of motion code, again, I will look up, and I don't have it on the top of my head, but I believe it's 95850 and 95851, but I will double check and send that to everybody. Is mobilization different than CMT, SMT? For example, mobilization, soft tissue mobilization. I think we talked about that in our conversation, but if you still, Dr. Misra, if you still have questions about that, please go ahead and contact me directly, and we can talk about that so much. Okay, so here's a really good question. How does one show improvement of ADLs when the patient only comes back when they're compromised? All OATs will show historically similar disability levels without the improvement immediately gained soon after a treatment. Okay, this all goes to, and you have a very, very valid question, and this is what patients often do. Because of their lack of education or their either it goes to one of two things, either lack of education or non-compliance, okay? So if it's a lack of education, then what has to happen is when a patient is released to supportive care, they need to be educated on what would prompt them to come back for routine supportive care, or an event that would prompt them to come back that would create an acute condition, okay? So if you're talking to the patient throughout their treatment plan about their ADLs, and then you release them from care, and you can relate back to those ADLs that you've discussed throughout their care plan, then you can tell the patient, okay, Joe, you remember when you first came in to see me, you told me that you are a recreational golfer, that you like to go out and play that noon game 5 times a week, and when you first came to see me, you couldn't even hold a golf club, much less swing one, because you had so much pain in your neck, radiating down through your fingers. You couldn't grip that golf club. Now look at you. Now you're swinging your golf club at full range of motion. You're back out golfing 5 days a week. If you ever get to a point where that begins to deteriorate, not to where it was when you first came in, but begins to deteriorate, you need to come in and see me so we can give you a few treatments and then get you back to your maximum medical improvement. Okay, so that's an educational thing. Now, sometimes it's a non-compliance. Sometimes you educate the patient and they just wait and wait and wait and wait, and finally when they come back, they're in really bad shape. And now you're going to need to put that patient on a micro treatment plan as a chronic patient to get them back to maximum medical improvement. And so you're going to have to re-evaluate and reassess those ADLs, have them do the outcome assessment again, and hopefully, the hope is they get tired enough of filling out that form every single time they come in because they wait too long. So I would say, it really depends on the patient. So let's see. 97140 should also allow active and passive manual stretching to increase joint at range of motion. Correct. That is correct. But what most massage, and we're talking about the difference between massage and manual therapy technique. Massage is stroking, kneading, they call tapotement or tapping. And if that's all that's happening, then 97140 should not be billed. Okay, so you need to know what the nature of the massage is, whether we're dealing with deep tissue, active passive manual stretching, which is considered manual traction, and that is definitely a component of the 97140 code. So that's a good question. Many auto carriers now are denying eSTIM after the first month, and yes, that is true. They are denying eSTIM after the first month, and it unfortunately the science is supporting them. So that one is going to be a hard one for you all to, if you do personal injury and you want to appeal that, that's going to be a hard appeal because the science is on their side. If you go back to that table where it says eSTIM isn't even a warranted, it is a therapy that should not be given in the first month, then the question is what do you substitute it with? What you substitute it with are your range of motion exercises, your passive and active range of motion exercises, and you begin to move them quickly away from the passive therapy and more into the active therapy. So that would be the overarching recommendation for treatment of whiplash injuries. I don't see any other questions. Okay, there's one. Okay, Dr. Mishra, maybe on this particular question on the oath, you and I can talk one-on-one. So whenever you have a chance, give me a call, and we can talk about that particular issue privately. Dr. Cipher wrote, what if you have a gimpy knee? Then a whiplash. Shouldn't this be accounted for as a confounding issue? Yes, it should be for sure. My number to call is on the first slide, and so you should have received the handout, but I will type it in here. And this is my cell phone number. And then my office number is 866-942-5655. Do we have any other questions? All right, I'm going to take that as a no. I want to thank everybody for coming today. I'm going to turn the recording off now.